Hi everyone, I'm Dr. Ilajan Khandelwal, and in this module we are going to do the pathology questions which were asked in the November INI-CET exams. Now students, if you ask me that ma'am, how was the paper? Regarding, as with all the INI-CET exams, this exam was also of medium to severe difficulty level, right? As with INI-CET students, a lot of repeat topics were there, but the options were really confusing and some of the questions were of very high difficulty. So I would not say that it was an easy paper. The paper had a medium difficulty level. Regarding pathology students, if I tell you the question distribution, approximately 20 questions were asked with overlaps. A lot of questions from systemic pathology were there, right? From general pathology students, the topics which were asked were granuloma. You know, TB and granuloma is a very, very important topic in all the MCQ exams, whether it is INI-CET or NEET or FMG. Granuloma and TB is one topic which you need to know, right? Then students, there were two questions which are asked on match the following from general pathology. One on the oncogenes and one on the different modes of inheritance. Both of them were fairly easy questions, but students got really confused between the options, right? Then there was a question on the dye which is used in immunohistochemistry, which was an easy question, but it was a really practical question. Regarding hematology students, the two most favorite topics of the examiner were iron deficiency anemia and megaloblastic anemia. Surprisingly, there were no questions on leukemias, but these were the two topics which were asked, and fairly easy questions were there from these topics, right? From systemic pathology, there were a lot of questions. Two questions from kidney was asked. One on RPGN and other was protein electrophoresis and nephrotic syndrome, right? That was also a practical question. Then students, there was a question on the stain which is used in female genital tract, that is the cervical smear. That was also a practical question, right? Then from heart students, there were two questions, one on cardiomyopathy, which was an image based question, and another was the sampling in infective endocarditis, right? Breast, one of the favorite topics of the examiner is the molecular classification of breast cancer. So there was a fairly easy question on the molecular classification of breast cancer which was asked, right? Now there were two other questions which were asked from the genital system, one on the markers in Seminoma and other on the images of Leydig cell tumors which were there. These were the questions which were told to me by the different students. So we are going to discuss all these questions one by one, right? Now before I start with these questions, I would just like to reiterate this fact of pathology, that the eyes see what the mind knows. If I don't know what to look for in the microscope, my eyes cannot look for those things, right? So during medicine and pathology, you have to keep your eyes and your ears and your brain open, right? With this basic knowledge, now let us start with the different questions. The first question is, a patient with rapidly progressive renal failure presents with crescentric glomerulonephritis, which is found to be pauci-immune. Which of the following antibodies are involved in this condition? This was an easy question. See, they have told you that the patient has got crescentric glomerulonephritis and the patient has rapidly progressive renal failure. That means what are they talking about, students? They are talking about rapidly progressive glomerulonephritis, right? Now they have told you that this patient has got pauci-immune rapidly progressive glomerulonephritis, right? Pauci-immune. Remember students, I told you that RPGN is of three kinds, type 1, type 2 and type 3. Which of these RPGNs is pauci-immune? The RPGN which is pauci-immune is type 3, right? And in that is usually ANCA associated. What is an example of a pauci-immune RPGN? The example is Wegener's granulomatosis, right? So it is neither GBM associated nor immune complex associated, it is ANCA associated, right? That is why the answer in this question is very direct. The answer is going to be ANCA. What is ANCA? ANCA is anti-neutrophilic cytoplasmic antibody. What are the two types of ANCAs which are there? P-ANCA and C-ANCA. Which condition will you see C-ANCA? Wegener's granulomatosis. In which conditions will you see P-ANCA? Microscopic polyangiitis and Churg-Strauss syndrome. Understood? So what is the answer in this question? It is ANCA. Now, what are the other two types of RPGNs? One is called type 1 rapidly progressive glomerulonephritis, which is usually anti-GBM associated. What is GBM? Glomerular basement membrane. And the example in this condition is Goodpasture syndrome. Type 2 RPGN is immune complex associated, and the example here is SLE or polyarthritis nodosa. Understood? What are the other options which were given in our question? Which of the following antibodies are involved in this condition? One option was ANA. Where will you see ANA, students? Anti-nuclear antibody will be seen in SLE. So, here the patient will have type 2 RPGN. Understood? And that is not post-immune because this is an antibody. ANCA we have already done. Anti-GBM is basically type 1 RPGN. That is also not post-immune because it is antibody mediated. Anti-PLA2R is seen basically in membranous glomerulonephritis. Membranous, right? So, understood this question? This was a fairly easy question which was asked, right? Now, regarding students' crescentric glomerulonephritis, two other points which I want to tell you. Why is it called crescentric glomerulonephritis? Because the glomerular biopsy shows glomeruli with more than 50% crescents. That means if my biopsy has got 10 glomeruli, more than 50% glomeruli are going to show you crescent. What is a crescent, students? A crescent is a half moon. In this image, can you people appreciate this is how a normal glomeruli looks like? Can you people appreciate this is the glomeruli? And these are the tubules. This is another glomeruli, students, right? When you see this biopsy, can you people appreciate this glomeruli? Do you think it looks similar to this? No, I don't think so. It has a lot of cellularity, and if you see, you can see that there is a formation of this half moon which is there. This half moon is basically called as a crescent. That is why it is called as crescentric glomerulonephritis. If my kidney biopsy, more than 50% of glomeruli are going to show you crescents or half moons, I call it as a crescentric glomerulonephritis, right? Another image, students, showing the same thing. This is one glomeruli, this is two glomeruli, third and fourth, right? In this glomeruli, can you people appreciate this? This is a crescent. Another crescent, students, just like this. Then, students, another crescent just like this. So, I can see that three of the glomeruli are showing me crescents. So, this is called as a crescentric glomerulonephritis or rapidly progressive glomerulonephritis. Understood? Okay. Then, students, let us move to the next question. A 26-year-old patient presents with a history of headache, fever and neck stiffness for several days. Now, if my patient had this history of fever, headache and neck stiffness, what do I think of? I usually think of a diagnosis of meningitis. I think about meningitis. CSF analysis reveals the following parameters. CSF protein is 62, glucose is 20 milligram per deciliter. They have given you the normal plasma glucose, normal glucose level is also 140, and white blood cell is composed of lymphocytes. What is the most likely diagnosis? Tell me people, what is the most likely diagnosis? The diagnosis in this case is tubercular meningitis. You will ask me, ma'am, why is the diagnosis tubercular? One, because they have told me that WBC, it is mostly composed of lymphocytes. Now you will say that, ma'am, lymphocytes are seen in viral meningitis also, right? So how do I differentiate? How do you differentiate? You differentiate on the basis of this glucose level. In this case, the glucose level is reduced. The CSF glucose level is reduced, and that is seen in TB meningitis. That is why that is the answer. In Coxsackie meningitis or HSV meningitis, the glucose level is totally normal. Although the white blood cell is usually composed of lymphocytes, but the glucose level is normal. That is why that is not the answer. In bacterial meningitis, lymphocytosis will not be there. There will be neutrophilia. So that is also not the answer. The answer directly is tubercular meningitis. Understood? Okay. Let's move to the next question. A transbronchial biopsy of a patient with fever, cough and weight loss shows the finding of the biopsy below. If you get this question on fever, cough and weight loss. In India, the first diagnosis which I think about is tuberculosis, right? They have given you a biopsy picture, and what do you see on this biopsy picture, students? Do you think it is a granuloma? Right, I showed you this picture n number of times. Can you people appreciate that in this center, this pinkish material which I have is necrosis, right? Then students, can you people appreciate there are certain cells which have got this slipper shaped nuclei, the stretched nuclei. What are these cells which I am talking about? These are the hallmark cells of a granuloma. These are basically the epithelioid cells. And here, not clearly seen, you will see a giant cell, right? So that means they are talking about a TB granuloma, right? This is a classical case of a TB granuloma, one of the favorite topics for the examiner. Every year in INI-CET, they will modify the question and they will give a question definitely on TB or granuloma, right? So, they have asked you which of the following chemical mediators are involved in its pathogenesis. Tell me, what type of hypersensitivity is granuloma formation, students? Type 4 hypersensitivity. Which is the cytokine which is involved in granuloma formation? Remember I told you G for granuloma and G for gamma. It is interferon gamma. So that is why directly what is the answer in this question? The answer is interferon gamma. If interferon gamma was not there in the option, the other answer could have been interleukin 12. Understood? Okay. What are the other options? One of the options is bradykinin. What is the role of bradykinin in inflammation? It is a very important pain mediator. C5a. C5a is an anaphylatoxin. It helps in anaphylaxis. So, which cytokine is raised in allergic reaction or anaphylaxis? It is C5a. Prostaglandins. What is the role of prostaglandins? The role of prostaglandins is fever and pain. Understood? Easy story till now. What is a granuloma, students? A granuloma is basically a collection of modified macrophages. And what are these modified macrophages called, students? These modified macrophages are called as the epithelioid cells. They are the hallmark cells of a granuloma. They are surrounded by a collar of lymphocytes and sometimes a giant cell, right? So, what are the components? They have necrosis, epithelioid cells, giant cells and lymphocytes. See this picture. In this picture, can you beautifully see these? What are these, students? These are basically the giant cells. These are also giant cells which are seen, right? Dark blue cells. Can you appreciate all these dark blue cells? What is this? This is basically a collar of lymphocytes. In between, can you appreciate some cells which have stretched out nuclei? These are basically the epithelioid cells. So, a patient with a history of fever, cough and weight loss, right? In India, with a biopsy showing giant cells, always think in terms of a granuloma, right? Now, if they ask you what are the diseases in which you see granuloma, this is another thing which is important, you should know. One is TB. Now, you people will say that, ma'am, TB will always show caseating granuloma. No, remember, TB can show both caseating and non-caseating granuloma. If I ask you, is there any other condition in which you see caseating granulomas? Yes, that's also a question. The answer is fungal infections like histoplasmosis or coccidiomycosis. That also shows granuloma formation, right? Then sarcoidosis typically shows non-caseating granuloma. Sometimes you get a clinicopathologic question on sarcoidosis also. A transbronchial biopsy of sarcoidosis is also given. Non-caseating granuloma image can be given. There can be what is the pathogenesis or what kind of hypersensitivity, again type 4 hypersensitivity. In addition, in the questions, clinical scenario, they can give you that the patient has hypercalcemia or increased ACE level or hilar lymph node enlargement. Done? Lymphogranuloma venerum, leprosy, syphilis. What stage of syphilis shows granuloma? Tertiary syphilis or gamma. Cat scratch disease usually shows a stellate or a star-shaped granuloma. Wegener's granulomatosis is one type of vasculitis which shows granulomas. Crohn's disease, berylliosis, and chronic granulomatous disease, right? These are some other conditions which will show granuloma formation. Regarding TB granuloma, remember, grossly or when you do a FNAC, what do you see? We see a cheesy material, and that cheesy material is due to caseation necrosis. That is why it is called as caseating granuloma, because you will see some cheesy material, right? It is not completely solid and not completely liquid, right? And on biopsy, you can see both caseating and non-caseating granulomas with what kind of giant cells in tuberculosis? Langerhans giant cell. How do you see? How does a Langerhans giant cell look like? You will have a necklace or a horseshoe arrangement of nuclei, something like this. Understood? Then students, when you do a staining, what special stain is used in tuberculosis? The answer is, you will see acid-fast bacilli. It will be AFP positive, acid-fast bacilli are seen. Understood? Let's move to the next question. You have a 55-year-old male patient with a history of infective endocarditis who presents with high-grade fever, new onset murmurs and splinter hemorrhages, right? What is the correct way to collect the blood culture samples? How do you collect the blood culture samples, students? Firstly, how many samples do you need? You need 3 sets of culture samples. 2 from the peripheral lines and 1 from the affected wall with a gap of 30 minutes between each collection. So this was a direct ratification question, students. This is what we require in an infective endocarditis patient. So this was the answer. Understood? The next one, which of the following stains are used in the cervical smear below, right? So it was something like this which was given. You were seeing something bluish. What stain is used for cervical smear, students? This was a very direct question. You don't have to put your brain. In cervix, what stain do we use, students? We do a pap smear. So we do a Papanicolaou stain. So what is the answer here? The pap stain. Toluidine blue, students, is basically a metachromatic stain which we use for mast cells. Remember in INI-CET 4 years back there was a question, what is the stain for mast cell? Answer was toluidine blue, right? So this is a stain for mast cell. HNE is the most common stain which is used in histopathology, right? And Giemsa, students, is one of the stains which is used in peripheral smear. It can be used to stain H. pylori bacilli also, right? It is used in peripheral smear or to stain the Helicobacter pylori bacilli. Done? Easy? Okay. Let's move to the next question. A 60-year-old vegetarian presents with fatigue, weakness that has been present for a few months. Remember, students, I told you, whenever you are given a history of a vegetarian, this has become really common these days. What you have to think of, students? I have to think of megaloblastic anemia due to deficiency of vitamin B12. If you remember my videos, I told you that this is an important clue in a clinical pathology question. Vegetarian diet, think about B12 deficiency anemia. Why? Because a very important source of vitamin B12 is the non-veg diet like fish, liver, egg yolk, right? So students, I am a vegetarian. I have vitamin B12 deficiency. These days you will see that a lot of patients who are vegetarians, they are having vitamin B12 deficiency, right? Let us see what the question is. On physical examination, pallor is noted. That means my patient has anemia. Hemoglobin is 9, the patient has anemia. MCV is increased at 110 femtoliters. What is the most likely diagnosis? My patient has got anemia and the patient has got high MCV. What is the diagnosis? Megaloblastic anemia. Why is the answer not iron deficiency anemia? Because in iron deficiency anemia, MCV is low. It is an example of microcytic anemia, not macrocytic anemia. So this cannot be the answer. Understood? And iron does not have any relation with vegetarian or non-vegetarian. Aplastic anemia. Aplastic anemia patient usually has pancytopenia which has not been given. The MCV is also usually normal. Thalassemia, MCV would be totally normal in that case. That is why, students, the answer here is megaloblastic anemia, right? If you remember this table which I told you, students, then it will be a cakewalk, this question. I told you this table of microcytic, normocytic and macrocytic. Microcytic, when the MCV is less than 80 femtoliters, normocytic when the MCV is between 80 to 100 femtoliters, and macrocytic when it is more than 100 femtoliters. Which conditions do you see microcytic anemia? The answer is going to be CETA, sideroblastic anemia, iron deficiency anemia, T for thalassemia, and A for anemia of chronic disease. I'm sorry, in this question I told you thalassemia has got normocytic anemia. No, thalassemia is an example of microcytic anemia, right? So here the MCV in thalassemia is going to be low and not normal or high. Understood? So, CETA is the mnemonic which you have to remember for microcytic. So, in the MCQ exam, if it is given that the MCV is 60, 65, 70, that is less than 80, always think about these differential diagnoses. On the other hand, if the MCV is high, more than 100, you have to think about LHMC, Lady Harding Medical College, which is a very popular medical college in Delhi, only for girls medical college, L for liver disease, H for hypothyroidism, M for megaloblastic anemia due to B12 deficiency, and C for cytotoxic drugs, right? So you have to remember about these things. In this question, because the MCV is 110, more than 100, what you think about as the answer, it is going to be megaloblastic anemia due to B12 deficiency, right? Now, in one of the INI-CET exam, students, this image was given regarding the megaloblastic anemia. There were pigmented knuckles. In this picture, can you people appreciate the knuckles here? See the knuckles which are here, they are pigmented. So, pigmented knuckles are also seen in vitamin B12 deficiency, right? What are the other clues which are there in a clinicopathologic scenario of B12 deficiency? Vegetarian diet, right? Gastrectomized people or ileal resection. Why? If you remove the stomach, students, the parietal cells of the stomach help in the absorption of vitamin B12, right? So, if you remove the stomach, there will be no parietal cells, intrinsic factor is not going to bind to them, so there will be B12 deficiency. Similarly, the most common site of absorption of vitamin B12 is ileum, terminal ileum, right? If you remove the ileum of the patient, so if in the question it is given that the patient has got ileal resection, it will lead to B12 deficiency. Done? Then the most common worm which leads to megaloblastic anemia or B12 deficiency anemia is fish tapeworm or Diphyllobothrium latum. That was a question once, right? If they ask you what is the most common worm which leads to iron deficiency anemia, the answer is going to be hookworm or Ankylostoma duodenale, right? Clinically, the patient has got anemia, beefy tongue, pigmentation of knuckles or neurological complications. There is pancytopenia due to nuclear cytoplasmic asynchrony, and there can be increased risk of thrombosis also, right? Two images which you need to remember. One, this is also given macrovalocytes. Can you see? The cells are macrocytic and oval. Another very important image which is given is that of a hypersegmented neutrophil. Hypersegmented neutrophil. What is a hypersegmented neutrophil? Which has got more than 5 lobes. In this neutrophil, can you people appreciate how many lobes are there? 1, 2, 3, 4, 5, 6, 7, 8, right? So, more than 5 lobes are there. This is a hypersegmented neutrophil which is seen in B12 deficiency anemia, correct? Lastly, students, when you do a bone marrow aspirate, what do you see? On bone marrow aspirate, why it is called megaloblastic? Because you see megaloblast. How does a megaloblast look like? It has basically sieve-like chromatin. So, can you people appreciate these erythroid precursors? See the chromatin that is immature. This chromatin is basically called as a sieve-like chromatin. So, we have erythroid precursors with sieve-like chromatin. Understood? Next question. Which of the following proteins show a marked increase in size in nephrotic syndrome on serum electrophoresis, right? Now, you all know that nephrotic syndrome has got massive proteinuria. It has got massive proteinuria, more than 3.5 grams per 24 hours, right? And which protein is usually excreted in the urine, students? It is usually albumin, right? There is hypoalbuminemia. So which proteins will increase? If albumin is decreasing, which proteins will increase, students? All these proteins are going to increase on electrophoresis. But the most important protein which is going to increase is alpha 2 globulin. That is why that is going to be the answer, right? Remember this graph which I told you in nephrotic syndrome. This is the normal electrophoresis which you see in a patient, in a person. This is albumin that is there. Then you have alpha 1, alpha 2 globulins, beta globulin and gamma globulin, right? What happens when my patient has got nephrotic syndrome? This is the graph for a patient of nephrotic syndrome. Albumin level is reduced, whereas alpha 2 globulin level is the maximum which is increased. Even gamma and beta will increase. So what is going to be the answer, students? It is going to be alpha 2 globulin, right? Next question. Sickle cells have got high mechanical fragility and high osmotic fragility, high mechanical fragility and low osmotic fragility, low mechanical fragility and high osmotic fragility, low mechanical fragility and low osmotic fragility. Students said that, ma'am, we got really confused in this question. It's a bit confusing, right? Now, they have told you that sickle cells, first imagine they have high mechanical fragility or low mechanical fragility. What is the shape of RBC, students? RBCs are biconcave disc-like structures. Why are they biconcave? Because see, this is a blood vessel, right? Now, it has to pass through the blood vessel. RBCs are biconcave because they can modify their shape according to the area from which they are going, and that is why they are biconcave. If my cells are now sickle cells, they are unable to get modified, right? And that is why they are really fragile. They can be easily destroyed, right? That is why it leads to hemolysis. So will they have high mechanical fragility or low mechanical fragility? They will have high mechanical fragility, right? So we are left with these two options of high mechanical fragility, right? Then low osmotic fragility or high osmotic fragility. Remember, students, I told you sickle cells and thalassemia have got low osmotic fragility. What has got high osmotic fragility? Hereditary spherocytosis. The osmotic fragility is high. The osmotic fragility is low in sickle cell anemia and thalassemia. That is why, what is the answer which you are going to say? It is going to be this one, high mechanical fragility and low osmotic fragility. That is going to be the answer. Understood? Next question. Transferrin saturation is decreased in which of the following condition? You tell me what is transferrin first of all. Remember, I told you, students, transferrin is the transportation form of iron. So suppose, students, this is iron. Iron is transported by binding to transferrin, right? So if my iron level is low, of course, transferrin saturation is going to be low, right? Of course, right? So what is going to be the answer, students? Iron level is low in which of the following conditions? Iron deficiency anemia. That is why transferrin saturation is decreased in which condition, students? Iron deficiency anemia. Hemosiderosis and hemochromatosis have got high iron level. If the iron level is high, of course the transportation form of iron, that is also going to be basically totally saturated. So transferrin saturation is going to be high. Understood? Pernicious anemia is not related at all to iron deficiency anemia. It is related to B12 deficiency anemia. That is why this cannot be the answer. What is the answer? Iron deficiency anemia. Every year, students, whichever exam you are appearing for, iron deficiency anemia and iron metabolism is one of the favorite topics for the examiner. So let us quickly revise it. What are the other things which we need to know for iron deficiency anemia? Most common worm, hookworm. Site of maximum iron absorption is duodenum. Factors increasing iron absorption are ascorbic acid or citric acid. Storage form of iron is hemosiderin or ferritin. The transportation form of iron is transferrin. Which is the master regulator of iron metabolism? It is hepcidin. Last year there were two questions on hepcidin which were asked, right? The clues in the history, if there is a clinical history about iron deficiency anemia diagnosis, are elderly with GI malignancy, pica. If they give you a history that the child is eating, the sand or clay or mitti, think about iron deficiency anemia, right? Plummer-Vinson syndrome, there was a question on this also. It is a combination of atrophic glossitis, esophageal webs and iron deficiency anemia. So that is another MCQ which you need to remember. Understood? Then, when you see the nails of this patient, there is koilonychia or spoon-shaped nails. So, pigmented knuckles seen in B12 deficiency anemia, spoon-shaped nails or koilonychia seen in iron deficiency anemia. Understood? Then, students, when I see the peripheral smear, macrovalocytes and hypersegmented neutrophils seen in megaloblastic anemia, and smaller. Can you see? A lot of these RBCs are quite small, and see the pallor, they have more than 1/3 pallor. So they are called microcytic hypochromic RBCs. They will be seen in the peripheral smear of iron deficiency anemia. Understood? Here, students in iron deficiency anemia, even the red cell distribution with RDW is increased. There is a lot of anisopoikilocytosis which is usually seen. Even students, when we see a case, what we have observed that if my patient has got iron deficiency anemia, there is compensatory thrombocytosis. So, I see a lot of patients of iron deficiency anemia who have got high platelet count. You can think about that also, right? Another important thing which you need to know of is something which is called as the Menzer index. There are MCQs on that also. What is Menzer index? It is MCV upon RBC count. What is the formula? It is MCV upon RBC count. That is the Menzer index. That is another MCQ. It is high, that is more than 13 in iron deficiency anemia and less than 13 in thalassemia. That is another MCQ which you need to know of. Understood? Okay, let's move to the next question. Match the following genes with their associated cancer types. This was a direct Ratta question. You can only do this question if you have done revision at least twice or thrice, because these genes are quite confusing, right? Now, first of all, we have KIT. You tell me, out of these options, KIT is seen in which condition? Remember, students, KIT is seen in gastrointestinal stromal tumor. So, 1 is associated with C, right? So, GIST is associated with C, KIT. That is why, students, in a patient of GIST, what is the marker which we use? C-KIT positive. What is the most specific marker if they ask you these days? DOJ1. Understood? Okay. KRAS. Remember, students, RAS is the most common oncogene which is affected in human malignancy, and I told you KRAS is there in pancreatic cancer. So, 2 is associated with D. So, 1C and 2D. Let us see. JAK2. This is a very easy one. JAK2 V617F is increased in myeloproliferative disorders. So, 3 is associated with A. And last is ALK. Remember, ALK is seen in lung cancer. So, 4 is associated with B. So, 1C, 2D, 3A and 4B. What is the option? B option is the answer. Understood? Regarding match the following, students, the good part is even if you know 2 out of 4, like out of these, if you know the JAK2 one, if you know the KIT one, and if you know the ALK one, you don't even remember RAS one, you will be able to mark the answer correctly. That is the beauty of match the following questions. Understood? Easy? Let's move to the next one. A 75-year-old woman with diabetes and hypertension has a biopsy of her heart that is shown below. What is the diagnosis? Now, students have told me that there was an image of cardiac biopsy, ma'am, in which a lot of pink material was given. I don't know which image was exactly that, but here in this image, can you see this pink material which is there, right? They said, ma'am, a lot of pink material is there. When you see a lot of pink material, students, in a biopsy, and there is a history of diabetes and hypertension also which is given, that pink material can be amyloid, right? And if it is amyloid, can you people tell me in which type of cardiomyopathy you will see amyloidosis? Amyloidosis in heart is associated with which type of cardiomyopathy? The answer is going to be restrictive cardiomyopathy. So students, if the image was showing a pink colored material, right, you have to think that this pink colored material can be amyloid, and amyloid is associated with restrictive cardiomyopathy. That is why this is going to be the answer, right? What kind of a material which you see here? This is kidney biopsy. Can you appreciate this pink material? This homogeneous pink material is basically amyloid, and when I do a special stain, that is Congo red under polarizing lens, I will see a apple green color. I will see a green apple color. Why do we call it as a apple green birefringence? Because it looks like golden apple or green apples. That is why the color looks similar to that. That is why it is called as apple green birefringence. Understood? This is another image can be asked, right? Now, 2 or 3 extra points which I am going to tell you regarding cardiomyopathies which can be asked in your exams. First of all, students, dilated cardiomyopathy. In which all conditions will you see? This is the most common type, and it can be seen in alcohol, postpartum, cardiotoxic drugs like adriamycin or doxorubicin, hemochromatosis, that is another question, or genetics. So out of dilated cardiomyopathy, you have to remember these 4 causes because they can be asked in your exams. Hemochromatosis can be associated with both dilated and restrictive cardiomyopathy, but a better answer to mark is dilated cardiomyopathy. Understood? Histologically, students, this is one latest image. This image can be asked in the next paper also, that this is the cardiac biopsy, and in this, can you people appreciate these nuclei in the center? Don't you think they look like ninja stars? Ninja stars are like these, right? These are called as the ninja star nuclei. And these ninja star nuclei, where will you see them? They are seen when the dilated cardiomyopathy is due to titin gene mutation. So, if there is dilated cardiomyopathy due to titin gene mutation, it will show ninja star nuclei. This is another potential image for future exams. Done? Then students, if my patient has got hypertrophic cardiomyopathy, remember most of the patients are due to genetic cause. What are the 2 genes that can be affected? Beta myosin heavy chain and myosin binding protein C. So that is the next MCQ which is there. The genes which can be affected are beta myosin heavy chain and myosin binding protein C. They are the genes, right? And grossly it will show banana split configuration. Next MCQ. One MCQ is this. Next is banana split configuration is seen in here in HOCM. And last is another clue in the history can be athlete with sudden cardiac death. Whenever there is a runner or an athlete or a young patient with sudden cardiac death, one diagnosis which we think about is HOCM, hypertrophic cardiomyopathy. That is another question which you have to remember. It is the most common cause of sudden cardiac death in young athletes. Understood? On biopsy, students, this will show a helter-skelter arrangement of the muscle fibers. In this image, can you people see the haphazard arrangement of muscle fibers? So, this is called as a helter-skelter arrangement or a haphazard arrangement of muscle fibers. Haphazard arrangement of muscle fibers. Done, students? Easy? Okay. Next question. Post-orchidectomy, a patient's histopathology slide shows rods of ring case crystals. Very easy question. I told you ring case crystals are seen in Leydig cells normally, and if my patient has got a Leydig cell tumor, it will show lots of ring case crystals. They have directly told you that the slide is showing ring case crystals. That is why, students, the answer is going to be Leydig cell tumor. Understood? Easy. It's not going to be gonadoblastoma. Sertoli cell tumor, I told you one marker which is very important, that is inhibin. Yolk sac tumor, I told you histopathology is important, that is Schiller dual body or glomeruloid bodies, right? So, Leydig cell tumor associated with ring case crystals, that is the answer. Fairly easy question. Next. A woman presents with a fixed nodule in her breast with nipple retraction. Biopsy shows HER2 positivity. Which chromosome is responsible for brown color in the IHC stain? Remember students, I told you, whenever any immunohistochemistry is positive, it is going to show you brown color. So if on IHC staining some brown color is coming, I say that this is IHC positive, right? Now, they have asked you that what is this brown color due to? So we pathologists call it DAB. What is the full form? Diaminobenzidine. So the answer to this question is direct. It is diaminobenzidine or DAB. The IHC positivity is the brown color is due to DAB. Understood? In future exams, the question can be on FITC students. FITC is basically the stain which is used in flow cytometry. It is the stain which is used in flow cytometry. Done? Easy? Let's move to the next question. Match the following genetic disorders with their inheritance pattern. Again, a easy question. Cystic fibrosis, Leber's optic neuropathy, Duchenne muscular dystrophy, myotonic dystrophy. Now, if I am the students, first of all, what I totally definitely know. Remember, I told you Leber's hereditary optic neuropathy, mitochondrial inheritance, right? So, B is 4. That I definitely know. Now, in all these options, B is 4. This is not going to help me out, right? I also know Duchenne muscular dystrophy. Remember, I told you DMD, Duchenne muscular dystrophy and Becker's muscular dystrophy. Both of them are X-linked recessive, right? That is why C is 3, B is 4 and C is 3. That means I am left with these two options, A and C. Now, regarding the other option, students, one option is called myotonic dystrophy. Remember students, when we do autosomal dominant disorders, and I told you the mnemonic for modes of inheritance, I told you the mnemonic is he has a very dominant father, and D for dystrophia myotonica. That means myotonic dystrophy is an autosomal dominant disorder. That means D is 1. Remember that? D is 1 is only seen in this option, that is A. That is why students, what is the answer here? The answer is A, that is A2, B4, C3 and D1. Understood? Easy? That means cystic fibrosis is going to be autosomal recessive, that is A2. Clear? Remember, I told you the mnemonics for all modes of inheritance, and that is very, very important for us to remember. Even in FMG exam, they are very frequently asked. So, what was the mnemonic for autosomal dominant? He has a very dominant father. What is the one which is for autosomal recessive? A, B, C, D, E, F, G, H, I. All inborn errors of metabolism, enzyme deficiencies are usually autosomal recessive with a few exceptions. A for ataxia, alpha-1 antitrypsin deficiency, alkaptonuria. B for beta thalassemia, C for congenital adrenal hyperplasia and cystic fibrosis, D for deafness, E for emphysema, F for Friedreich's ataxia, G for Gaucher's and glycogen storage disorders, H for hemochromatosis, homocystinuria, and I for inborn errors of metabolism, right? X-linked recessive disorders, the mnemonic is Lady Harding college girls don't care about foolish words. L for Leishman, H for hemophilia A and B and Hunter syndrome, C for color blindness, G for G6PD deficiency, that is an exception, D for Duchenne muscular dystrophy, C for chronic granulomatous disease and color blindness, A for A gamma globulinemias, that is Bruton's, F for Fabry's and Fragile X, W for Wiskott-Aldrich syndrome. Very, very important. You have to remember this mnemonic and these disorders. Lastly, mitochondrial inheritance, also a very popular and hot topic, students. Few things which you have to remember. M for mitochondrial and M for maternal. It is always maternally inherited. That means from mother, it will go to all the kids. You can see in this pedigree. From this father, it's not going to go to another kid, any of the kids. So it will stop there. From this mother, it is going to go to all the kids. From this father to none of the kids. Understood? So this is mitochondrial inheritance which you need to know. It is exclusively maternally inherited, usually involves those organs which have a lot of mitochondria like brain, eye or skeletal muscle. What are the examples of disorders? Melas, Leber's hereditary optic neuropathy, Leigh syndrome, Narb syndrome, or chronic progressive external ophthalmoplegia. Understood? Easy till now? Next question. Seminomas are positive for which of the following immunohistochemical markers? Students got confused in this question also. Remember when I told you seminoma students, I told you they are positive for PLAP, placental alkaline phosphatase, one of the favorite markers which the examiner asks. But some of the latest markers which are seen in seminoma are OCT34, NANOG, right? They are also there. CKIT. So PLAP is there, OCT4 is there, CKIT is there. These are the other markers which are seen in seminoma. HCG can also be rarely increased, but not that popularly. HCG will increase more commonly in choriocarcinoma. What is the answer you will write? They are positive for which markers? The answer is going to be 1, 2 and 3. A bit of confusion because some students said that ma'am we have marked 1, 2, 3, 4. HCG is not very much increased in a seminoma. That is why the answer is going to be 1, 2, 3. Understood? This is a table, students, which I have got because a lot of questions are asked from genital system. That is why let us quickly brush it up. Serous epithelial tumors will show Seminoma bodies and they will have marker CA125. Yolk sac tumor, the very popular image which is given in the question paper is Schiller dual body or glomeruloid body. They will be positive for alpha fetoprotein and alpha 1 antitrypsin, very, very important. Teratoma will show skin, bone, cartilage, hair, you know. Choriocarcinoma, HCG positive. Embryonal carcinoma, CD30 positive. Granulosa cell tumor will show Call, Exner body and coffee bean nuclei. Sertoli cell tumor, I've already told you, inhibin. Leydig cell tumor, we have another question about that, that is Rinke's crystal. Dysgerminoma, which is a ovarian counterpart of a seminoma, will show PLAP and LDH positivity. Brenner's tumor, transitional epithelium, that is bladder-like epithelium and coffee bean nuclei. Krukenberg's tumor will show signet ring cells. Understood? So this is a very important table from genital system, usually asked in the exam. Next question, students. A 62-year-old woman presents with a hard, irregular, fixed and non-mobile lump in her breast. Nipple is retracted and skin is discolored, lymph nodes are enlarged. What does it mean if the tumor is luminal type A? They just want to ask you that the patient has got luminal A tumor. What do you mean by that? Remember, students, I told you, what do you mean by luminals? Luminal means the tumor is ER-PR positive, right? HER2 status can be variable, but it is ER positive. So the option can be ER positive, ER positive, ER positive. These three options can be there. First option is ER positive, HER2 negative with mild to moderate proliferation. That is actually the answer. That is called as luminal A. B option is ER positive, HER2 positive. That option is actually luminal B. When the patient has triple positive tumor, ER, PR positive and HER2 positive, we call it luminal B. ER negative, HER2 negative, we call it basal-like. It is not luminal. And ER positive, HER2 negative with high proliferation, that is also not luminal A. So what is the answer? ER, PR positive, HER2 negative with mild to moderate proliferation. This question comes from the molecular classification of breast cancer, and this molecular classification of breast cancer, students, is one of the hottest topic for the examiner. They ask a lot of questions, right? This molecular classification is based upon the receptor status, that is ER, PR, HER2 status. You see these three receptor status and then comment. If that is not given, then you can also write down it is based upon gene expression profiling, right? First option, it is based upon ER, PR, HER2, or the second option, it is based upon gene expression profiling. Done? Another thing which can be asked, students, is this image. You have to remember. First category is called luminal A, that is ER, PR positive and HER2 negative. In this image, can you people appreciate this is ER? Can you see the brown color? Why do you see the brown color? Because of diaminobenzidine or DAB, right? This brown color has come, that means this is ER positive. Again brown color is seen, ER positive. HER2/neu is not seen, HER2/neu negative. So ER, PR positive and HER2/neu negative is luminal A. Understood? Then students, second image I can see ER is positive, PR is positive, HER2/neu is positive. It is a triple positive tumor. It is called luminal B, right? Third image, you can see ER negative, PR negative, HER2/neu positive, right? It is called as a HER2/neu positive tumor. It is called as a HER2/neu positive tumor. And in the last image, I can see ER negative, no brown color, PR negative, no brown color, HER2/neu negative, no brown color. This is a triple negative tumor and this is called as basal-like. If my examiner asks, out of all these, which has the worst prognosis, basal-like out of these has the worst prognosis. And out of these, which one has the best prognosis, students? This one, luminal A, is the most common and it has the best prognosis. Understood? With this, students, we have finished off all the questions which were asked in the pathology exam in November INI-CET, right? So, with this, students, I will end this video. Lastly, I would just like to say, one day you will look back and thank yourself for not giving up. Please do not give up, students. Please continue to work hard. Continue to do your bit. If you don't give up and continue to do your hard work, you will definitely succeed one day, right? Thank you so much, everyone, and all the best.